Welcome everyone to the Economics of Aging Spotlight series entitled, Can the Cost of Caring for an Aging Population Be Controlled? We're delighted to have everyone join us today. This particular webinar is focused on the costs of caring for an aging population. The concerns about unsustainable health spending typically dominate the discussion about population aging. However, research that has been done by the Observatory, some of it in cooperation with us here at the WHO Kobe Center, has shown that population aging is not a major driver of growth in health expenditures. Nevertheless, policy choices about how health services are delivered, the prices paid for health services, medicines and technology, and the volumes of care will ultimately determine about how aging societies affect health spending patterns. So we're here today to talk about the implications of these findings. My name is Sarah Louise Barber. I'm the director of the WHO Kobe Center. We collaborate closely with John, Silas, and Gemma, who are working with us on some briefs related to the economics of population aging. Today, we have with us some excellent speakers. Liisa-Maria Voipio-Pulkki is the CMO of the Finnish Ministry of Social Affairs and Health. Previously, she was employed as a senior medical advisor of the Finnish Association of Local and Regional Authorities. And since 2014, she's been actively involved in the Finnish government's health growth strategy, focusing on the implementation of innovations in health systems and the impact of the act on secondary use of health and social data. We're delighted. Thank you very much for joining us. Recently, she has been a core member of the COVID-19 steering group at the ministry. We have Bridget Johnston from Trinity College, Dublin. She's a research assistant in public health and primary care, an economist focusing on applied health system research, including evaluation of palliative care interventions across healthcare settings and the affordability of healthcare for households in Ireland. Thank you so much for joining us. Gemma Williams from the European Observatory on Health Systems and Policy. She is based at LSE and conducts comparative health system research, focusing primarily on health workforce, health financing policy, inequalities, healthy aging, digital health, and migration health. So lots and lots of really interesting topics. Thank you so much for joining us there. And of course, John Silas of the European Observatory, who is head of the London hubs of the European Observatory and a senior research fellow at LSE Health. His main research is on health systems, focusing primarily on health financing policy, health economics, and health system performance. He has worked in quite a few countries in the European Commission, OECD, and WHO. Thank you so much, John, for joining us. So I think we'll go ahead and get started. We have a very tight agenda today. Warm welcome to you. I'd like to go ahead and hand this over to John for an overview and a discussion of the PASH simulator. John?
Thank you, Sarah. So last week, let me share my screen. So last week we started off by talking about, there we go, some myths related to population aging, and we focused on how aging affects the economy and revenues for health. So today we're going to talk about spending. And so one of the big myths about aging and health spending is, of course, that older people are in poor health, that they will use a lot of healthcare services, and that this will be very expensive. And of course, the thinking is that by having more and more older people who are costing more per person and potentially with growing costs because they're a much larger market for healthcare, that this will lead spending to grow out of control. And if we believe the arguments, the myths from last week that aging is bad for the economy and it's bad for generating tax revenues, and we also believe that aging will accelerate health spending, then of course the only solution is to cut back on the welfare state and reduce coverage, reduce the health system spending. So I want to show some evidence about this. So this first slide, this first figure, this comes from the Aging Working Group of the European Commission. This is per person spending on health by age, by 5-year age group, between 2007 and 2016, so over about a 10-year period. I think the first thing to point out is that actually one of these myths is to some extent true. spending does, by and large, on average, increase by age per person. So we see here for small children around ages 0 to 4, spending is a bit higher. Then it slows down. Spending is a bit lower for people of teenagers, working age. And about around age 50 or so, it starts to accelerate, and it accelerates till about age 80, 85. And after age 80, 85, spending either flattens out or it slows down. It's really hard to know. Obviously, there aren't that many people above age 90 to really get a good sense of what's going on. Now, the first thing I want to point out that I think is interesting here is that these relationships are remarkably stable over a 10-year period. So there was a lot of aging that occurred between 2007 and 2016. But nevertheless, we really didn't see, you might expect that having a lot of older people might create a big market, that then suddenly, drug companies would be sort of targeting new expensive therapeutics at these people, and you would see some sort of divergence in spending at these older ages. And we really don't see that happening, at least in Europe on average. But nevertheless, we do see that older people are per person spending more, or spending on their behalf is higher than for younger people. So does this mean that aging will lead to uncontrolled growth in health spending? Well, if we take these patterns and we assume that they last forever, or that they last into the future, which seems to be reasonably plausible given the at least the last 10 years and experience in other settings as well. If we just look at the changing age mix of the population, and we apply these different spending levels to those different age groups, we can estimate the contribution of population aging to health spending growth. And we've done that here for the United Kingdom, shown in blue. So in blue, this is the additional growth per person attributable to the changing age mix of the population. And we see this is about a 0.5 percentage point on average at the most, which is around around 2030 to 2035. Now, if we compare this to average annual growth in public spending on health in the UK between 2010 and 2018, which was about 2.3, 2.4%, we see that this 0.5% of growth is really not that big compared to total spending. So it's about a quarter or less of spending. So even though spending is higher at older ages on average, and populations are aging will never become a major driver of health spending. It happens too slowly. And actually, it's not even aging itself that's driving health spending. That's driving these higher spending levels at older ages is actually the costs at the end of life. So here we have data. These are somewhat old data from Canada. This shows people who how much money was spent on their healthcare in over a 6-month period for people at age 65, 75, 85, and 90. And these people all survived beyond that 6-month period. And what we see here is, of course, that spending, the level of spending does increase somewhat with age. So it's about double spending for the average 90-year-old who lives, who survives. It's about twice as much as for the average 65-year-old. So there is higher spending by age. But where the real high spending is coming in is for people who die in the next 6 months. So among people who were age 65, who passed away within the following 6-month period, their spending was about 16 times as high as for comparable 65-year-olds who did not die. And this relationship continues even to older ages. So for a 90-year-old with 6 months of life to live, their spending was around 5 times as much as someone who survived. So it's not aging that's driving these healthcare costs at the higher healthcare costs at older ages. It's costs at the end of life. So is it everyone at the end of life? Does everyone cost a lot? Well, not really. So this is data that's coming out of a new policy brief that we just released recently on end of life care. This is data from Ireland. And what this shows the distribution of spending at the end of life. And so what we see here is that about 2/3 of spending at the end of life is attributable to just around 10% of people who die, about 10% of people who are in their last year of life. And if we look at the two deciles to the right, the 9 and 10, so around 20% of the population is responsible for around 80% of end-of-life care. So this relationship that we saw in the beginning of higher spending at older ages is really driven by end-of-life care for a very small percentage of the population. If we want to understand, well, if we want to do something about the spending, and we want to make sure that the spending is rational, we need to understand what the spending is on. And many people would probably think that the bulk of this spending is on long-term care, is on nursing homes. However, it turns out, looking at Ireland and looking at other countries as well, that the majority of this spending happens in hospitals. So in Ireland, where this data is from, more than half of spending is in hospitals. Around 30% is on long-term care, residential care services rather. So I think if we want to talk about, obviously we don't need to be that worried about aging as a driver of health spending, but nevertheless, if we want to do something about costs at the end of life, this gives us a sense of where we might want to target our efforts. Now, obviously, to understand, I've showed data for Ireland, I've showed data for the UK. If we want to understand how aging affects health spending, we might want to look at this on a country by country basis. And so we've created a simulator, the PASH simulator, which I talked about last week. It's the Population Aging Financial Sustainability Gap for Health Systems. And what this does is this assumes that the way that we pay for healthcare stays the same. The way that we spend by age stays the same, but the age mix of the population changes. And so the way it works is we pick a country, make some assumptions about how health spending varies by age for that country. And then we see how the changes in the population age mix will affect both the revenue side of healthcare as well as the expenditures. And the difference between these two, this is the financial sustainability gap, which is attributable to aging. And then, of course, in the simulator, which is available on the Observatory's website. So if you look for the PASH simulator on the website, you can play with this and look for your own country. But you can explore policy options to see whether or not you can fill the financial sustainability gap attributable to aging. So last week we randomly picked a country. We were lucky enough to pick Slovenia. I hope we can pick another country randomly today that will be interesting. Let's see. Here we go. And okay, Finland. How exciting. So is Finland a good country to pick? Well, Finland is one of the most rapidly aging countries in the EU. So we can see here, this is data from Eurostat. It had the largest increase in the share of its population over age 65 over the last decade. It has very diverse sources of funding. So we talked last week in the webinar about aging and revenues, how diversification is more sustainable than relying on labor markets or relying on a single source of a single revenue base for health that might be affected by aging. So it probably doesn't have, I don't know, we'll find out, but it probably is not so affected in terms of revenues by aging. But its spending it's above the EU average, and there have been concerns in Finland about the cost of aging, especially in rural settings. It's historically has been a municipality-driven health system, and so there are concerns, of course, if you have lots of older people in rural communities, will they be able to cope with rising healthcare costs? So let's go to the simulator. Okay, so here we are on the Observatory website. So we've chosen Finland. So we can see here, this is the population age distribution for Finland. This is data from the UN, so it's not the same as the Eurostat data, but it's very similar. And what we can see here is that the big changes are really among the working age populations, which is expected to shrink over the next 80 years or so, from 56% of the population to about 50%. I think the most stark change in this figure is among the 85 plus. So currently people over age 85 are around 3% of the population in Finland, and that's expected to more than triple by the end of the century. So 1 in 10 people in Finland are expected to be over age 85. So now we make some choices about health financing. So I'll talk very quickly. The bottom left this shows the mix of revenues that are used to finance health in Finland. As I mentioned, it's quite diverse. It's a mix of taxes on income, profits, and capital gains, and taxes on goods and services, so consumption taxes primarily, as well as a bit coming from social contributions. But putting the revenues aside, we're going to focus most of our attention on health spending. So the health spending by age, right now I've chosen the EU average. So this is that same curve that I showed in the very first slide coming from the Aging Working Group. So this is assuming that Finland's health spending follows roughly the pattern of the average EU country, which again is fairly low over the younger working age and then increases pretty steadily until about age 75 or 80, and then slows a bit. And so what we're going to do is we're going to combine the revenues data, expenditure data, and the population age mix, and we're going to get a sense of what the population what the financial sustainability gap is attributable to population aging. So here we go. Okay, so this is our projection. So we've indexed everything to 2020. So we assume that per person spending is perfectly financed in 2020, just for the sake of the projection. And so what we see in green is revenues and in red is expenditures. So as perhaps expected in green, revenues are pretty stable as the population ages in Finland, again, because it's quite a diverse mix of taxes. It's really the expenditures that are expected to increase. So if spending by age in Finland is comparable to the EU average, we would expect by 2050 a financing sustainability gap of 0.7% of GDP, which, if for those of you who were here last week, is a bit lower than in Slovenia, where we have revenues and expenditures both diverging. Now, as I mentioned, spending in Finland is above the EU average. So let's say, hypothetically, that Finland spending by age is not like the EU average. Let's assume, like we see here in this dark blue, that spending increases exponentially with age. And of course, we talked about, I showed in the earlier slide, that the population over age 85 is expected to increase substantially. It's expected to triple by the end of the century, at least. So what would this do to the projection if we assume that spending was much higher at older ages? Well, here we have the forecast. Of course, revenues are unchanged. Now, the shape of the curve for expenditures is quite similar, at least it looks similar. But we do see, of course, that there is a much larger gap. So a 1.1% of GDP financing gap is attributable to aging if we assume that, that spending at older ages increases exponentially. And so, like I said, this is all driven by spending. There's not really a revenues issue here. So I think with that, I will pass it back to Sarah and see if we can hear if there's anybody that can talk to us a bit about what's going on in Finland and what these results mean.
It's a very interesting presentation. As you mentioned, the per person spending is increasing, but an important question we have in the comments from Philip Domansky is asking about the number of people in certain spending. So the number of people, while the number of people is increasing, isn't that driving spending? And I think you've addressed that, showing that the population aging is very slow, and that the major determinant is our policy choices that we make. If there are, so we will go ahead to hand it over to Liisa-Maria to talk about Finland. Thank you very much.
Thank you very much, Madam Chair, and greetings from Helsinki, Finland, and thank you for the invitation. As we just heard, and I think it's quite true that not aging per se, but the way that we organize the services plays a major role in the cost containment in the years to come. Plus, of course, the way that we take care of the last 6 months of the end life care. But let's talk a little bit about Finland. There has been a long tendency in Finland, both from the politicians' side and from the professional sides, to get away from institutional care of elderly people, to support more home or home-like housing facilities as the site of care, even the end-of-life care. But how do you manage this in a country like Finland? Of course, we do have big cities, but we also have big rural areas when the distances to healthcare centers are long. And on the other hand, in Finland, even the elderly population is now quite used to internet and to digital tools, and they actually start to ask for such services also in healthcare, not to say a word about other fields of services, starting from banking and so on. So I thought that I might want to share with you some details of the national project called the CATI program, Smart Aging and Care at Home, which now covers population-wide maybe half of the Finnish population, geographically a little bit less, but represents different regions, different ways of municipal or regional-based ways of organizing health and social care in the country. So this is a governmental program lasting for 3 or 4 years, and its main aim is to advance the take-up of technology and to support home-based care of elderly people using technology. It was preceded by a 2-year-long scientific preparatory phase where the technologies, health technology assessment, ethical aspects, research designs, and so on were carefully planned. But now it is actually officially part of the health and social care reform from the service development side of the reform. And it's backed by a legislation which was submitted to the parliament just about 1.5 months ago, which calls for higher staffing for institutional care for elderly people, but also is the legal background for both our citizens, customers, and the healthcare organizers to implement the results of the CATI program. And there is still quite an extensive follow-up evaluation and scientific research program around the whole thing. Next slide, please. So the objectives of the project are operating models and services will be reformed by utilizing technology, as I already said. But actually the main aim is to maintain the functional capacity and well-being of these people who live at home or in home like housing facilities, to support independent and high quality of life, promote services brought to home. So that is also how the professionals do meet these people who live at home, and increase the well-being and actually reduce or focus better the workload of home care staff themselves. As I said already, this is a nationally coordinated project, and it also has the responsibility to include social partners and companies in a true public-private partnership fashion to deploy technologies and to improve also the business that has great opportunities around this new way of performing work. Next slide, please. So what kind of new technologies are we actually talking about? There is a really long list, but I just picked a few. Remote monitoring and home care service. Well, this is sort of, already established in many parts of the country, but what is perhaps new is AI-based alerts based on the various data collected at home. And the great idea is that remote home care would be the default service for a new client. So every new client receives an individual evaluation and tailored combination of applications that suit best for her needs and the physical surroundings and maybe the geographic location where the client lives. And also, there's quite a lot of attention paid to how practitioners, nurses, doctors, social care workers can make use of the new technology. They need training, but we also need virtual or physical showrooms for all the adults learning of technologies and how these home-like living conditions are actually designed using new technology in a very versatile way. And there is, I just incidentally picked one example of the research that has been performed there all the time during this project about the elderly care workers' views and attitudes and values towards telecare robots. Interesting finding of how the attitudes actually became more positive with experience as they work with these robots. Can I have next slide, please? Very briefly, just introducing you the team. The Finnish Institute of Health and Welfare is the main actor here, and here you can see some people, and they actually are quite willing to share their experiences and network also internationally, just in case you happen to be interested in this kind of an approach. Thank you.
Thank you very much, Liisa-Maria, on that really interesting discussion on use of technology for home-based care. I'm sure there's going to be a lot of questions about cost and access, but we will be moving on to healthy aging strategies. Gemma, are you ready for us?
I am indeed. Well, thank you very much, Sarah. So as you just said, in my presentation, I'm going to talk a little bit about strategies to promote healthy and active aging. And so put very simply, good health at older ages is important from an economic perspective, as older people in good health use health and long-term care services less than people in worse health. And on average, they die at older ages. And together, this translates to lower per capita healthcare costs. So a healthier older population can therefore help to reduce the growth in health spending as a result of population aging. And in addition, it's important because it can help to improve the quality of life of older people and their friends and family. And if you want to see sort of by how much good health at older ages can help to reduce healthcare costs, please check out these two policy briefs, which cover countries in Europe, Asia, and the Western Pacific. So because of the importance of healthy and active aging, we need to think about what strategies we can adopt to promote good health at older ages. Because as we all know, there are major differences in physical functioning at older ages. So while some older adults have the physical functioning of much younger individuals, others need assistance to do everyday activities from the health and long-term care sector. Yet, contrary to what some people might believe, health at older ages is not random and is actually stuff that we can do to help promote good health throughout the life course. So of course, genetics plays a role and puts some people at greater risk of developing certain conditions. However, there is also health throughout our life is very dependent on the social determinants of health. So do we live in polluted cities? Are we rich? Are we poor? Do we work hazardous jobs? Do we have good access to healthcare? Are we in a situation to be able to adopt healthy behaviours? And thankfully, all of these social determinants on the right of the line can be tackled through multi-sectoral policy actions. And so in the next two slides, I'm going to talk a little bit about some of these strategies that can help promote healthy and active aging. And these start with those that create an enabling environment for remaining healthy and active, followed by interventions delivered primarily by the health and long-term care sector. And just to note that I've chosen to speak mostly about strategies that target older people specifically. But of course, if we really want to improve health at older ages, we have to take a life course perspective. So supporting healthy aging extends beyond simply treating illness in older adults. We have to create an enabling environment and help to foster lifelong healthy behaviours. So the first thing we have to do is to tackle ageism in society, because studies have shown that ageism leads to higher risk of premature mortality, worse physical and mental health outcomes, and faster cognitive decline. And countering ageism generally necessitates the development of strategies, policies, and laws. So some examples might be including age as a protected characteristic in Equal Opportunity Acts, or perhaps implementing employment equality laws to help promote employment for older people. Other strategies that have shown to be effective are promoting generational contact interventions, to promote interaction and contact between older and younger people. And the media also has quite an important role to play here in ensuring that positive portrayals of older people can be widely seen. Creating an age-friendly environment is also fundamental to promoting healthy aging, because the ability to remain mobile and to participate in social or community activities depends greatly on the physical environment in which we live. And an age-friendly environment are those that have affordable, age-friendly public transport. That neighbourhoods have to be safe, they have to be accessible, so they have to be, have sidewalks so people can go for walks, cycle lanes perhaps. We need age-adapted housing and buildings, accessible services, and also the widespread availability of technology is communication information tools is quite important so people can stay connected, so that they can manage their lives. and so that social isolation can be reduced. So, and the final strategy on this slide is promoting and enabling healthy and active lifestyles. And this obviously needs to be done throughout the life course. And while there are sort of strategies that we can adopt at the individual level to sort of nudge people towards adopting healthier lifestyles, really the most successful strategies to engender behavior change. So sort of making sure people don't smoke, they don't drink excess alcohol, they eat healthily, they are physically active, are those implemented at the population level. So these are things such as legislation and regulations restricting advertising of unhealthy products, taxes on unhealthy products, other financial disincentives or incentives to encourage take-up or not taking up unhealthy things. So, and when we talk about promoting and enabling healthy lifestyles, we have to talk about the social determinants of health, because really people's ability to be healthy is fundamentally dependent on the social determinants of health, which I spoke a little bit about earlier. So on the final slide, we're going to look at some strategies which are focused on the health and long-term care sector. Because to support healthy aging, it's not just treating disease, it's about transforming health and long-term care services to ensure they can meet the range of individual needs that older people have. And this means targeting primary prevention, as well as efforts targeting secondary prevention and trying to reduce frailty and to delay care dependency. So firstly, we need to improve coordination between health, long-term care and other services to help support aging in place. This might be with the housing sector, for example, or the voluntary sector. And within this strategy, an important component is training and upskilling health providers, especially in primary community care, to ensure they have the necessary skills and knowledge to provide holistic care to older people. And this means so they can identify care needs and developing personal care plans to try and target issues facing older people, such as preventing falls or slowing cognitive decline. And I should emphasize is that in many countries, a key component of this objective is to strengthen primary care so that it can fully meet the needs of older people in a cost-effective way. So the second strategy is to strengthen home care and support unpaid carers, because as we probably all know, in most countries, a large proportion of home care is provided by unpaid carers, such as family members or community volunteers. And unpaid carers themselves are actually at risk of negative psychological and physical health outcomes. And they can also have reduced opportunities for being involved in employment and to participate in social activities. So unpaid carers themselves need support, and this might be financial compensation, measures to support their health and well-being, or reconciliation measures to support continuing employment. And efforts to improve home care in many countries have focused on personalisation of care, and this has been shown to be quite an effective way to improve home care. And this might be through care vouchers, personalised budgets, cash for care programmes, and it always involves the older people in trying to develop their care plans to make sure it works for them. And finally, the last one is enhanced use of technologies, but I won't go into that because Liisa-Maria has already spoken about it. But it's just to say that's not necessarily the high-tech technologies. It could be about ensuring access to wheelchairs or hearing aids and that sort of aspect. So I'll hand back over to Sarah.
Thank you very much, Gemma. So the importance of healthy aging, to both quality of life as well as cost through not just health, but also health sector approaches, but also multi-sectoral approaches, a very important message there. Shall we move on to Bridget to talk about end-of-life care?
So for the next few minutes, I just want to talk to you a bit about some strategies or some policies that can be put in place to help address these challenges that have been highlighted. And there are a number of them that I'll go through. So firstly, helping people retain greater independence and reducing disability will be important. As Gemma has already highlighted and is included in the conceptual framework that is guiding the Economics of Healthy and Active Aging series. There's an important role for policies that promote active aging. And importantly, that's policies which encourage behavioral changes, such as quitting smoking, reducing alcohol consumption, and increasing physical activity. These all have significant positive health effects, even if those changes don't occur until older ages. And given that the majority of older people are living with 2 or more chronic conditions, improved disease management, including rehabilitation, will also be key to supporting people. This is because evidence shows that the main drivers of increasing social care costs, including costs incurred near the end of life, is disabilities. So disability is the main driver of cost near the end of life. And that's disability is measured by the activities of daily living and the instrumental activities of daily living scores. So this means that interventions will need to focus on both slowing or preventing disease progression, but also reducing the impact of disabilities on the viability of people remaining cared for at home or in their place of preference. There is now a good body of studies demonstrating that rehabilitation interventions in particular can improve the activities of daily living scores in people with life-limiting illnesses across a range of settings, with improved experiences for patients in many cases, also lower costs. So it's important it brings not only better experiences and outcomes for patients, but also that it can lead to reduced formal service costs. So the next point I've highlighted is that it will be important to focus on those most at risk of receiving high cost, low value care. That is care that's unlikely to improve their quality of life or extend their life expectancy. So we know from studies that high cost decedents tend to have multiple chronic conditions, often involving dementia, and are frail. And they're at high risk of futile and possibly even harmful investigations and treatments. So while we know the features of people who are likely to have high cost and poor experiences, there's a real challenge in identifying them in a timely manner as they pass through the care system rather than afterwards. So it will be important to develop tools that identify people with complex needs and the key strategies that will improve and change their care trajectories. And given that a large proportion of costs come from acute hospital admissions, as John has previously highlighted, this is an area that requires particular attention. Though the evidence base remains limited, it does to date suggest that interventions at the point of hospital access can improve care experiences for patients and their loved ones and lead to reduced overall costs. It'll also be important to balance or to improve the balance between treating disease and managing symptoms and quality of life. So palliative care team interventions have been shown to change care trajectories through multi-professional assessment and support for better choices and decision-making by patients and their carers' loved ones. Palliative care teams work across different settings, supporting people wherever they may be and providing that skilled multidisciplinary assessment of their needs on an ongoing basis. It's through this assessment and planning that it often helps reduce the number of unnecessary tests and interventions that people receive, which in turn can help limit the growth in costs. This change in care trajectories and the reduction of unnecessary care is greatest in 3 circumstances, the evidence suggests. When a person has multiple chronic conditions, when the intervention or the referral to palliative care happens early in the care trajectory, or when the person has cancer, although cancer does not need to be their primary cause of illness. Although this multidisciplinary assessment or palliative care intervention can be expensive, it can be more than offset, studies show, from the reduced utilization of high cost, low value care. Although with it brings the need for improving understanding and awareness of palliative care approaches amongst both healthcare professionals and the public. That's so that this shift isn't seen as giving up, or that, addressing the idea that palliative care perhaps is only relevant in the last days of life. Instead, these approaches are about helping people to live as well as they can for as long as they are alive, and is not about shortening survival. In fact, one very prominent study suggests that palliative care can actually increase life expectancy when incorporated early in the illness trajectory. And finally, providing care that is aligned with needs and preferences. So improving outcomes isn't just about saving money. It's also about ensuring that care aligns with what people need. And that means that the planning should be informed by what patients want and need, and also how that may differ from their loved ones' goals at times. We know from previous studies that people may have their experiences improved by facing as few barriers as possible to accessing the services they need. So addressing those barriers will be very important. For example, financial barriers to accessing services at the point of use have been shown to increase stress for both patients and their loved ones, and may ultimately lead to greater spending in these situations. And we've also found that continuity is highly valued, and frequent referral to different services is disliked. So it is important to ensure that the points of access to services are well understood by people, and that navigating the system is made easier for them. Care pathways will need to be flexible and allow choices for change as people's preferences and their needs evolve. So there needs to be an integrated care pathway that allows people to evolve for their understanding, for their needs to develop and progress, and for systems or services to be responsive to that. It's also important to highlight in all of this that we're ensuring that this isn't simply cost shifting. So we're not shifting the costs of formal services onto informal caregivers, and that we're choosing interventions and strategies that are supporting caregivers at the same time and not increasing either their financial or the social burden that they experience.
I think I'll hand it back over to Erica, who's going to tee up a number of questions that we've been receiving in the chat box. Erica, would you like to show us what people are asking?
Yes. Hopefully you'll get time for 2 rounds of questions. So if your question isn't asked, please do put it in the chat box. But some pretty fundamental questions have been coming through. So one of them is whether or not we have any real world examples of countries that have actually achieved healthy aging as a result of national policy. So are there any countries that have actually managed to do that, given it's very difficult to address the commercial determinants of health, socioeconomic inequalities, things like this? So any real world examples, that'd be really interesting. Also, people want to hear more about the robots. That's probably a question for Liisa-Maria. But yeah, more information about the robots would be greatly appreciated. People are very interested in that. As you probably anticipated, in a lower income setting, what would be the best, the cheapest hanging fruit, if not the lowest hanging fruit? And also, if we're building home care capacity and investing in tech, is this just shifting spending from healthcare budget to the social care budget? Or are we externalizing the costs for unpaid care? And if we're not doing that, then actually will it save money? Or is this more about improving quality of life and quality of care rather than actually reducing the budget? And one final thing, this is probably a question for John, but how does this model square with the European Commission's work on the Ageing Working Group and the fiscal sustainability reports that do see ageing in a number of countries as being a threat to fiscal sustainability over the medium and longer term? So some very good questions coming in, but keep them coming in. Okay.
John?
Maybe I'll take that first question about the Aging Working Group. So this is a good question. So the PASH simulator on the expenditure side is completely analogous to the approach used by the Aging Working Group. So as we saw from the projections for Finland, we could see that spending over the long term does lead to more, aging does lead to more spending. I think there's 2 points to raise. The first is that the rate of growth of that spending increase over time is very slow. So in any given year, the main driver of health spending growth is not going to be aging. And so obviously this means that, if we're talking about 0.5% per year, of course it will compound, but it gives us lots of time to develop policies, to develop strategies to try and make sure that this 0.5% is not so damaging. The second difference between the patch simulator and the aging working group, which I think is important both conceptually as well as for policy, is that we bring revenues into the mix. And obviously we saw last week, for those of you who were here, that in a country like Slovenia that relies very heavily on labor market financing to pay for health, as people are retiring, as people are aging, there's a dual effect of spending, of increased growth in spending, as well as reductions in revenues. And so we see this in countries like Slovenia, Estonia, Bulgaria, and a lot of this wouldn't necessarily be illuminated or highlighted in the aging working group projections. So in aging working group projections, you might see that spending does not necessarily increase very much, but revenues could fall by nearly as much in some of these countries. And I think the second, much more policy relevant thing to raise here is that in the aging working group, by only looking at spending and showing that spending over a 30, 40-year period increases due to aging, the only policy option that it highlights is to reduce spending, because we're only looking at the spending side. And so I think that to have a much more holistic look at how aging affects health financing, public finance, more generally, we need to understand both the revenue side and the expenditure side, because in many instances, there may be solutions on the revenue side that help to deal with the expenditure side. Speaking from, I'm originally from the US, and I remember every year growing up, everyone talks about when Medicare or Social Security, which is like a public pension, when it will go bankrupt. And no one talks about the fact that very small incremental changes in the contributions for these systems would actually negate the costs associated with having more people receiving them. So I think if we want to have an honest conversation about sustainability, we need to look at expenditures and revenues. And so that's what we're trying to do here. But I will pass it back to Sarah. Thank you for the question.
Before you pass it back, do you want to address the other question on spending, which is whether or not home care spending is just shifting money from health to long-term care sector?
So I didn't even see that question, but yeah, it's a good question. Obviously, it depends on the nature of how health and long-term care are financed. So in the case where they would be financed under a pooled budget, then there's obviously incentives to control costs overall. But I think that it's a fair point that, where it's one of the reasons that integrated health and social care, not only delivery, but also financing, is so important, because it removes the incentive, obviously, to shift costs onto other providers. And we see this, of course, not only in the case of aging, but with other, if you look at, again, not to make too many references to the US, but you look at accountable care organizations in the US and the idea of sort of shared risk by a pool of providers. The same, of course, is true on the budget side, that if you have shared budgets by across sectoral budgets, even by health and social care or health in other sectors, then there's an incentive to rationalize costs and make sure that we're not just shifting from one to the other. Thank you for the question.
Thank you very much. Do we have responses from some of the other queries about successful examples in other countries, particularly low and middle income countries? Gemma, do you have any ideas? Liisa-Maria?
Yeah, sorry, I just saw Liisa-Maria's hand up. But yeah, just going to the question sort of about the sort of concrete strategies for promoting healthy aging. This is an excellent question, because we do have lots of very good sort of national strategies, regional strategies. I'm actually going to put one in the box, actually, which is the WIPRO, Regional Healthy Action Plan. So I think this is an excellent strategy. But of course, the difficulty now is to sort of support countries in implementing all of the objectives of the plan. And it's very difficult in practice, because it sort of goes beyond the health sector, involves all sectors, all actors, lots more investment to sort of create these enabling environments for healthy aging. And so sort of it's a whole of government approach really to promoting it. And this is a very challenging thing to do. But there are countries that are quite successful. I think we've just written sort of country health profiles, which looks at all different aspects of country health systems. And I did Malta, and Malta are actually very good in terms of healthy aging. They have their strategies. They link these to concrete action plans to sort of try and promote health in different areas. But this sort of really is to promote health through the life course rather than sort of targeting older people specifically. And I think this is sort of something that countries could probably do better.
Liisa-Maria, would you like to discuss expenditures or examples or robots?
Okay, thank you. Well, when it comes to robots, so I put a reference in one of my slides. So for those who are interested in robotics, in elderly care or in healthcare, social care to begin with. So please go and check that lengthy paper that gives you many examples and also other references. But talking about, cost shifting, so in Finland, as you know, we have now a health and social care reform already in action, and it's all health and social care is under the same management and same budget starting from January the 1st next year. So it's not about cost shifting. And I would like to say at this point that it has been a political choice in Finland that we invest in elderly care right now, because it went a little bit too far in closing the institutional care settings and leaving people at home more or less on their own. So I think that this is the cost containment is among the aims or objectives of the CATI project, but it's only one of maybe 10 objectives. And I think that the most important thing is to support our professionals in adopting modern technology, which our customers, the citizens, want to make use of, to be able to stay at home, which they consider as a value of itself in getting old and also in healthy aging. So I think it's a political choice in this country, but in the long run, of course, the way that we organize care by, for example, making use of technology plays a role in cost containment. But right now, it's not a very hot topic. It's not in the focus of political discussion in this country. Over.
Bridget, would you like to add something on those aspects?
Well, just in terms of thinking about the cost shifting, I think it's also important to highlight that social care, at least in many countries, relative to other formal care services or health sector services, are lower. So even by shifting some of the care into social care, or having increased social care, you wouldn't expect the same rates of growth that you would if people remained within formal care services in the same way. So I think it's important to have that as well, that you might have an increased volume, but the rate of growth wouldn't be as high in terms of the overall costs, because those services aren't as expensive to provide in many instances and represent low value in many instances as well. So if we're thinking about efficiency, having people remaining in acute hospital beds when they could be better cared for at home or in the community is another thing to be thinking about in that context.
We do have a very important question in the chat box about a number of questions, an important example from Slovenia, but also dementia. How does dementia play into both the costs as well as the care environment, especially technology environment? Shall we respond to that quickly? John, does dementia?
Yeah, sure.
John, does dementia?
Sorry, just slow on the unmute. Yeah, I think especially again, I guess this is another strangely example from the US, but there's a new medication, Aduhelm, which is meant to be preventative for Alzheimer's and dementia, although it's apparently not proven to be effective. But the cost of this medication is something like $30,000 a year. So I think that there is a potential for dementia and dementia-related treatments to be very expensive. And I think that this also sort of highlights the role of policy, because you obviously, the decision to cover a $30,000 a year medication that has no proven benefits, I mean, you shouldn't have that shouldn't be, right? You should have technology assessment programs that can decide whether or not to cover these sorts of things. So on the cost escalation side, I think that there's obviously a risk of new treatments being developed at a very high cost that target dementia. But that again, there are policy interventions that can make sure that this doesn't balloon out of control. So that's all I wanted to add on that.
And shall I jump in and just say, of course, sort of, I think some people might think dementia is sort of inevitable as people get older, but of course there is emerging evidence now that being healthy and active throughout the life course can lower your risk of dementia. So that sort of really just adds sort of more evidence behind the fact that we really need to sort of promote healthy and active lifestyles.
I wrote it in the chat box already. So there's quite a lot of evidence to show that dementia cannot be perhaps abolished or cured, but it can be postponed at least, so to say. And I just call for all possible means to promote people's information about how to dementia can be prevented. They're more or less the same things that we know already that can prevent cardiovascular disease, cancer, and so on. But they also seem to have an impact on dementia. Over.
Thank you. Erica, do we have additional key questions from the chat box that I'm not seeing?
No, I don't think so. There's some very interesting things about the incidence of dementia, whether it's going up in some countries, whether it's going down in other countries. That's something that is probably definitely worth looking at. But I think we can move to the summing up. Yeah.
Okay. Okay. Great. Yes, this is a really great conversation. I wish we had a lot more time to continue. Shall I hand it over to wrapping up and closing the session and return to the PASH simulator? I don't think we have time to return to the PASH simulator, but I think this was a great discussion. Liisa-Maria and John, would you like to make some comments in wrapping up?
I'll just say, I think if we were to look back at the PASH simulator, I think we would see that by reducing per person spending at older ages, there is a substantial spending reductions in the future in a country like Finland, hypothetically. So I think that even though we know that aging is not the main driver of health spending, and we know that even within that it's end of life care to potentially be concerned about, that there are policy interventions that we can use to promote healthy aging, to promote rational end-of-life care, and that these ultimately, which we can see in the simulator, but of course, please feel free to play around with the simulator on your own, and we can see that these do have a material effect on growth in spending over time. So I think the takeaway message is really aging is not a big deal, but it doesn't mean we should just ignore it completely. There are still things that we can do to slow the rate of expenditure growth, provide rational care, and have it be sustainable. So thank you.
Do you have any quick closing comments?
Well, it was a great discussion and we are running out of time, but voters in many countries are getting older. And so how we treat our elderly people is a major political issue. Thank you.
Thank you very much. So thank you, everybody. I think the message is very clear. Aging is happening. It's happening, but it's happening at a manageable pace in which there are many, many policy options that we have, and we need to continue this discussion. So thank you, everybody, for joining. Thanks to all the panelists. And there is the last webinar in the Economics of Aging series is on February 1st. Please join us. Is the politics of aging creating conflict between generations? Thank you, everybody. Thanks, everyone, for joining us.